Okay, everyone, thank you so much for coming to the lecture. And today I'm going to give this lecture about targeted cancer therapy and drug resistance. We probably could spend a whole semester to talk about different aspects in targeted cancer therapies, but today we only have about 15 minutes. So I'm only going to give a brief introduction to some key concepts in the research of cancer targeted therapy and drug resistance. Cancer cells have acquired several malignant capabilities during multiple tumor development steps. For example, the tumor can evade the growth suppressors, they can sustain proliferative signaling so they can grow forever, and also they can avoid immune destructions. For many years, people have been struggling very hard to figure out different therapeutic approaches to inhibit different malignant capabilities of the cancer cells. And all of these therapeutic approaches are defined as targeted cancer therapies. In general, there are two broad categories of anti-cancer therapies. The first broad category is called chemotherapy. These drugs are cytotoxic drugs. They will kill fast-dividing cells non-specifically. But because they will kill fast-dividing cells, the chemotherapy will also bring quite a bit damage to the tissue cells, so they have high side effect. And the second broad category of drugs is called targeted cancer therapy. As shown here, they will inhibit a specific aspect of the malignant cancer hallmarks. So they are more specific and hypothetically less toxic to normal cells. And there are two broad categories of targeted cancer therapies. The first broad category is called tumor-targeted therapies. In other words, these therapies are trying to target some specific aspect in the tumor cells to stop the tumor growth and metastasis. And the second broad category of targeted therapies is called immune-targeted therapies. Instead of working on the tumor cells, this type of therapy will interact with the tumor immune microenvironment. They will try to boost the immune system to recognize and attack cancer cells. And the lecture today will be more focused on the first category, which is the tumor-targeted therapies. And I think another postdoc from your lab, Avi Sahu, will give a more focused lecture on immune-targeted therapies next time. So let's first look at some famous examples of tumor-targeted therapies. Well, sure, do you know how could I remove the top panels here?
If you don't cover there, it will go away.
Go away, okay, hopefully. Please go away. Okay, the first and the most well-known examples of tumor-targeted therapies is this drug, Gleevec. This drug is a tyrosine kinase inhibitor in the treatment of chronic myelogenius leukemia triggered by the Philadelphia chromosome, and I will explain what is Philadelphia chromosome later. This drug was invented in 1990s by Siga Gagi, and later Novartis purchased this company. And in the year of 2001, this drug was approved by FDA at USA. Let's look at what this drug brings to the CML patient. Compared to the previous therapy, chemotherapy and the interferon therapy, Gleevec is really bringing a significant improvement of the overall survival of all the cancer patients. So you can see that when the year is going on, most of the patients are still being good. So because of this drug, the 5-year survival rate was improved to 90% from 30%. And why this drug have such a magic efficacy? So here is the mechanism of a chronic myelogenius leukemia, which is called Philadelphia chromosome. So among this patient, there is a translocation between their chromosome 9 and chromosome 22. And this chromosome translocation will create an oncogene called BCR-ABL1. So the BCR gene, the promoter will be active constitutively. And because of this translocation, the ABL1 gene will also be always activated. and trigger the downstream growth signaling. And the Gleevec is a small molecule shown here. And this small molecule can block the kinase activity of the ABL1 kinase, therefore stop the downstream signaling on the tumor cell growth. So you can see that from the time point that the people discovered the Philadelphia chromosome as a mechanism of this CML disease, it takes about 40 years until the final approval of Gleevec as a drug on the market, which means that for the development of most anti-cancer drugs, it takes decades of years, a tremendous amount of effort until you get something that works so well. And the second good example of targeted therapies is called all-trans retinoic acid. This drug was used to treat a disease called acute premyelocytic leukemia. So for the patient with this acute premyelocytic leukemia, they will accumulate lots of immature granulocyte in their blood. So Dr. Zhenyi Wang from Ruijin Hospital of China has given a kind of a report in France in 1982 that using the all-trans retinoic acid, he observed many of the patients could get really good efficacy in this therapy. And you can see that because of this new therapy, compared to the conventional chemotherapies, you see a significant improvement of the overall survival rate of the patient. And right now, the 5-year survival rate of acute premyelocytic leukemia is about 90% right now. So, but it takes several years for people to finally figure out why all-trans retinoic acid works so well. It turns out that the mechanism is also due to a chromosome translocation. So a chromosome translocation between chromosome 17 and 15 will create an oncogenic gene between RAR alpha and PML. And this gene will band together with a co-repressor and stop the downstream differentiation of the myeloid cells. And the all-trans retinoic acid will bind to the RAR alpha gene and somehow make this gene stay together with a co-activator and promote the downstream differentiation of the immature granulocyte. So from these two examples, you can see that the targeted therapies, which aim to attack a specific oncogenic translocation, can bring really dramatic improvement of the overall survival rate of the patient compared to conventional therapies. But could we find more examples? Could we use exactly the same strategy of hitting the right target to promote the significant improvement on other cancer types? So here is some reality. Let's look at another famous example of the BRAF inhibitor. In skin cancer, there is an oncogenic mutation called V600E mutation on the BRAF genes. After the oncogenic mutation, the BRAF mutant will keep the activation of all of the downstream signaling pathways to promote the cellular promotion, the cellular proliferation of melanoma cells. And the BRAF inhibitor, which can specifically target this V600E mutation, will stop the oncogenic signaling. This seems to follow the same kind of precision medicine mechanism as the previous two examples. But does this drug work? Here is some number from the phase 2 clinical trial of this BRAF inhibitor. As we can see that the overall response rate is about 53%, which means after treating patients with this drug, only half of the patient will show an initial response. The other half of patients just does not respond at all. Actually, yeah.
Do they still have the BRAF mutation?
Yeah, they still have the BRAF.
They are only treating
yeah.
if they have
yeah.
the mutation already.
There is a test ahead of time. Okay. Well, surely embarrassingly, this panel still do not go away. Let me see. if I
It doesn't show on the video.
does show, oh, if it doesn't show on the video, maybe.
It doesn't show on the video.
Yeah, then it's good. Yeah. Okay. And among the half patients who respond to this type of treatment, the duration of response is only 6.7 months, which means after 7 months, all of the responders would not respond. And the overall survival rate of the patient with a BRAF mutant melanoma is only about 16 months, which is really not good. And let us look at more numbers. Right now, there are lots of FDA-approved precision medicine or targeted cancer therapies. And you can see that for most of these drugs, the duration of response is always less than 1 year, which means that these drugs only give the patient several more months of life, but they will not cure the cancer. And recently, I guess many people here might heard about the huge breakthrough of immunotherapies to treat cancers. And remarkably, the immune-targeted therapy can bring really long-lasting benefits on a subset of patients. You can see the long tail of the survival curve. But you can see from this curve that a significant limitation of cancer immunotherapy is that most of the patients, the majority of the patients would not respond to this type of treatment at all. So, and even in some cancer types that the cancer immunotherapy may not even bring a better clinical efficacy than the conventional chemotherapy. This figure is from a clinical trial of BMS. They compared their immunotherapy antibody nivolumab against the conventional chemotherapy and show no improvement. Could anyone make a guess how much money does BMS lose because of this single one figure? Okay. What? Millions of billions of dollars? Well, Sam, that's a very good guess. It is very hard to estimate the overall loss because of many secondary effects. But the BMS stock market, the stock price dropped $12 per share, which is 16% on the Black Friday announcement. And some investigators estimate that it's about $25 billion in total if you count the secondary effect. And among the patients who respond to the targeted immunotherapies, like they will also acquire drug resistance at a later time point. This figure is from a clinical study from Yale Cancer Center. They demonstrated that among the patients who somehow get a partial response to cancer immunotherapy at the very beginning, they will acquire resistance at a later point, sooner or later. So as a summary, drug resistance is really the key challenge of cancer therapy field right now. Like 90% of the deaths of the cancer is due to the acquirement or development of drug resistance. So ideally, when you develop a new therapeutic approach or new drug, you hope most of the tumor cells will be killed following this pathway. But unfortunately, the reality is that the cancer can either have an innate resistance to the therapy, or they can acquire resistance to the therapy at a later time point after a brief initial response. So let's look at several examples that what is happening beneath the drug resistance. Let's still take the BRAF inhibitor as an example here. So this is the MAP kinase pathway, which can sense the signals from the outer environment of the cells and trigger the cell proliferation through some internal cell signals. You can see that in order to trigger the final growth and proliferation of the cells, there are so many pathways that can accept signal from the outer part of the cell. And the BRAF inhibitor can only block these single pathways, but there are so many other ways. You can either activate some alternative pathways or simply activate some key genes on the downstream or upstream, which means a single hit is far from sufficient to somehow block the downstream cancer cell growth. So